All right, moving on to chapter 21, we're going to discuss the nursing care of the family during the postpartum period. So, learning objectives, I'll let you guys kind of read through those. So, we're going to start with the nursing care of the postpartum woman. Nursing care that focuses on the assessment and support of a woman's physiologic and emotional adaptation after birth. Care is wellness oriented and is best provided by an interprofessional team. And the typical hospital stay is usually 1 to 2 days after a vaginal delivery, and then it can be up to 72 hours for a C-section delivery. Now, I have seen some C-section moms go home earlier than that, especially if it's, they've had a baby or two before and they kind of know what to expect. Some providers may let them actually go home at 24 hours as well. It's very dependent on the patient and the provider preference. All right, so transfer from the recovery area. So transferring to the postpartum room once the maternal condition is stable. And so there are a few different settings. I think we had talked about this earlier on in the semester, but you're going to have either what's called LDRs or LDRPs. At TJ Sampson, you're going to have the LDRs, which is the labor delivery recovery rooms, and then they're going to be moved to a different location for their postpartum room. In some facilities, they have LDRPs, which is labor delivery recovery and postpartum, so which just means that the mom stays in the same room the entire time they're there. I just want you guys to, again, be familiar with that acronym just in case you happen to see it later on. So hopefully that will alleviate any confusion. So the post-anesthesia recovery, these are women who have received general or regional anesthesia. They need to be cleared by a member of the anesthesia team or a nurse prior to going to the postpartum area. And so with these patients, we're going to be, keeping an eye on their vital signs, their bleeding, staying on top of their pain management, also assessing their family dynamics and being very mindful of their culture, because a lot of times we're going to have the significant other or a family member sometimes are going to be allowed to come back to the recovery room with them in that first hour or two post-delivery. The baby is usually at the bedside as well, so there can be a lot of dynamics that happen during that time. And then what to include and report to the postpartum care nurse. So if this mom has had a C-section, we're going to give her maternity history, her gravidipara, any complications that she may have had during delivery, any complications that occurred during her C-section, maybe her blood type, if we're considering maybe doing a blood transfusion, any pertinent vitals or lab findings, all those things that you would generally are going to give in like a morning report, you're going to also give in this handoff report. So if you've not gotten a chance to be a part of that, next time you guys are in the clinical setting, I definitely ask to kind of sit in on that so you can kind of see how that transaction happens. Planning for discharge. This is going to occur from the initial contact with the mom until they go home. So we're going to start working on discharge from the moment they walk through that door. There is so much information that we throw at these moms in that very, very short stay that they have in the hospital. We want to make sure that they're very well educated prior to going home. So we're going to start this process very early on. So their length of stay is going to depend on a lot of factors. So again, a vaginal delivery compared to a C-section delivery. Their physical condition of the mom and infant. If the mom came in completely healthy with nothing going on versus a mom who was diagnosed with HELLP syndrome, those are two very independent situations, and so the outcomes may be a lot, very different as well, and so that can depend on when they're going to be discharged too. The mental and emotional status of the mom, social support at home, the client education needs. So again, you're going to have some moms who are going to be appropriate to go home in 24 hours, and then you're going to have some moms who need to stay that full 48 hours for that additional education and teaching. And then financial constraints. This is where insurance can play a factor. So especially those patients who potentially don't have any insurance, sometimes they just want to stay for that first 24 hours because they don't want to be charged for that second night. And so again, that all kind of comes into play, and it's very individualized at that point. Criteria for discharge. So length of stay depends on the factors. Again, we kind of talked about this already. And then the mother recovered and able to care for herself and her baby. So we have to make sure that mom's able to care for, again, herself, her baby, and then potentially, if there's other children involved, we need to make sure that she's appropriate to be discharged. Those at low risk may be discharged as early as 6 hours from a birthing center, and then again, that 24 to 36 hours from the hospital. Most providers will not release a mom before 24 hours just because that PKU test that has to happen with the baby. We talked about that a few weeks ago. That PKU test happens at 24 hours post-delivery on the baby. And so if the baby can't be discharged, usually we don't discharge the mom either. And so once that 24-hour mark hits, we are able to do that PKU test, then both mom and baby are usually discharged at that point if they're both candidates. Some reasons I have seen a provider allow mom to be discharged earlier than 24 hours is if there's been complications with the delivery or complications with the baby. So say the baby came out, had to go to the NICU, and now they're being transferred to a higher level of care. As long as that mom is doing okay, I have actually seen them discharge the moms even as short as a few hours post-delivery. If her bleeding's okay, if she's appropriately been educated on the risk and the risk of going versus the benefit of staying, a lot of times those moms will opt to go and be with their baby. So as long as she's an appropriate for discharge patient, they can be discharged a little bit early. But again, if mom's being discharged home with the baby, it's usually going to be after that 24-hour period. And then, of course, the typical stay is going to be right around 48 hours for a vaginal birth and 36 for a C-section. All right, so care management and the physical needs. So the ongoing physical assessment is going to happen throughout the remainder of the mom's stay post-delivery. And so we're going to be getting our vital signs, checking for our bleeding, and also doing our uterine massages and checking our fundus to make sure it's nice and firm. So again, all those things are going to happen very frequently after delivery, about every 15 minutes or so. And then after those first few hours after delivery, it's going to go to typically once a shift. This can vary depending on what's going on with our patient. So say if a mom has had chronic hypertension, we may be getting her blood pressures more frequently. If a mom has had some excessive bleeding post-delivery, we may be checking her fundus more frequently. So it's going to be very individualized based on what's going on with our mom. And so we're just going to need to look at our orders to depend on how individualized that care needs to be. Some routine lab testing that's going to occur. We're usually going to get a repeat CBC at about 24 hours post-delivery just to see, again, what does her white count look like? What does her hemoglobin look like? RhoGAM may be an indication. So if a mom has a negative blood type and our babies have a positive blood type, those moms may be required to get a RhoGAM injection. I think we may have touched on that a little bit, but we're definitely going to talk about it in the next couple of chapters. So just so that you're kind of familiar with that word. Again, nursing interventions are going to be very individualized based on the patient. We're going to want to prevent excessive bleeding. So that's, again, why those fundal massages are so important. We're going to be looking for maintaining our uterine tone and then preventing bladder distension. And so as that bladder starts to fill up, we've kind of already talked about that can sometimes cause that uterus to be a little bit displaced, and it makes it a little bit harder for that uterus to clamp down, which can lead to a postpartum hemorrhage. So we want to encourage those moms to keep their bladder empty, especially those first few days. So a mom who's had an epidural, actually that is one of the last sensations that she will get back is that urge to feel like she has to go pee. So sometimes those moms need to void and don't even realize it. And so we want to definitely encourage them to get up and void as much as they can, at least every couple hours. One thing that I would always encourage my patients to do is just say, hey, every couple hours when you're feeding the baby, once you're done feeding the baby, once you go ahead and get up and get yourself kind of cleaned up and go ahead and try to void. And that would hopefully prevent that bladder distension from happening. And then preventing any new infections. So some of the things that we're going to want to watch for in the hospital setting is we want to make sure that we stay away from anyone who's sick. So whether that is a visitor or staff members, we want to encourage them to stay home if they're sick, just because this is a very vulnerable population. Want to make sure that they're changing their pad frequently. So again, that's why having them pee every couple of hours, go ahead and change that pad. Make sure that they're using that peri bottle to stay nice and clean down there as well, just to prevent any type of infections. And then just being in the hospital in general, hospitals are just, while we try our best to keep them nice and clean, there is, a risk for picking up additional germs. And so, just telling them, like, don't walk around barefoot, don't, put your shoes on the bed, like all those things. Just sometimes it can be common sense type things, we just want to reiterate those things with our patients. And then kind of going back up to the preventing a distended bladder, with that, because that can lead to a postpartum hemorrhage. We've kind of talked about that in depth now, but it can also lead to a UTI. And so these patients are already at an increased risk for developing a UTI post-delivery. So again, keeping that bladder nice and empty will definitely kind of help with that as well. And so if, so we have a patient who is voiding every 2 hours and then her fundus is still a little bit boggy and distended, again, we're going to go least invasive to most invasive. We're going to, rub and massage that fundus. And, maybe sometimes as a last resort, we may even actually have to cath the patient just to get that bladder empty for her, just to prevent again, a postpartum hemorrhage or the risk for a UTI. Some of the other things that we can do as far as helping a mom void. So while that sensation is kind of one of the last things that they get back, what I always would do is take my peri bottle, and you can fill that up with this warm water and have the patient kind of squirt that over their bottom while they're trying to pee. So sometimes just that sensation will kind of urge them to pee a little bit. And it usually feels good too, especially if they've had like any type of tear or an episiotomy. It's going to kind of sting, that urine's going to sting that area a little bit. So if we can kind of dilute that urine a little bit, so as they pee, kind of squirt that peri water, or take that peri bottle and kind of squirt that water over that area, sometimes will kind of help them to start voiding too. Some other things that I've seen in clinic is we actually can take some peppermint oil and put it in a bedpan. There's a lot of different things that we try to do to encourage a mom to pee, but if all else fails, then we're just going to have to cath them. Like, again, that's the most invasive, but we can't just allow their bladder to continue to be full. So again, kind of thinking about that with a test question, that may be one where, yeah, we're probably going to try all those things, but least invasive to most invasive, because we can't leave a patient with a full bladder because of the risk that can come along with that. So promoting comfort with our patient, we're going to kind of talk through the non-pharmacologic and the pharmacologic interventions. So with the non-pharmacologic, that can be as simple as offering pillows or blankets to the patients, helping them get repositioned in the bed, especially our C-section patients who are on bed rest for several hours post-delivery. Our pharmacologic interventions may vary depending on the type of delivery they've had, a C-section versus a vaginal delivery, and what orders your provider has sent down for them. However, one of the best things that I have seen for a pharmacologic option is Motrin post-delivery. So during pregnancy, moms cannot have ibuprofen. It is a contraindication of pregnancy. They cannot have it. And so for whatever reason, after delivery, I have seen ibuprofen work wonders. A lot of times, those medications actually work even better than some of our controlled medications. So we always want to start with, again, your ibuprofen. If that handles their pain, we don't want to go to the oxycodone. So, but again, Motrin a lot of times will work, or Motrin ibuprofen will work wonders for those patients. We want to promote rest for our patients as well. So a lot of times after delivery, they're kind of on that adrenaline high post-delivery. And so we want to encourage rest, limit our visitors. Sometimes, visitors don't understand that this mom has been laboring all night and all day, and they're completely exhausted. And so we definitely want to kind of be mindful of that and allow her the opportunity to get a lot of rest. This may even mean taking the baby to the nursery if she requests as well, just to give her that opportunity. Promoting ambulation. So we want them up walking, quite often after delivery, especially those moms who've been on bed rest post C-section. We're going to want to be mindful of them and make sure they're up walking as well. Maybe have them do a couple of laps in the hallway every few hours, just making sure, again, we're going to try to prevent any type of blood clots and things of that nature. Just we don't want them just laying in the bed for the 2 or 3 days while they're there. Promoting exercise. So with that, you're not going to do a ton of exercise, obviously, right after delivery, but that's something that we're going to discuss as far as what that needs to look like going home post-delivery, when they will be released from their provider to resume exercises, and all that is included in their post-discharge teaching. Nutrition, we want moms to resume their normal diet. A lot of times they can have things in their diet that they haven't been able to have up until this point during their pregnancy, things they potentially have had to give up. So again, we're going to promote good nutrition, promoting normal bladder and bowel function. So we've kind of talked about the bladder and how important it is to keep the bladder empty. But then with bowel function, we got to think about they are at risk for constipation just because they're on pain medication, especially with our C-section moms. So a lot of times these patients will potentially be put on a stool softener as well, just to prevent any type of constipation. Promoting breastfeeding, we want to initiate breastfeeding within the first 1 to 2 hours post-delivery. It's often called that golden hour. And so we're going to get into breastfeeding in greater detail on another chapter later on. But for now, just know that that first hour to 2 hours post-delivery, when mom's in that recovery phase, that is the opportune time to start breastfeeding. Breastfeeding is a complete supply and demand system. So the quicker we start that process, the quicker your body knows they need to start making milk. We're going to have that baby in skin-to-skin contact for usually that first 2 hours post-delivery as well. So again, that's just why it's a great time to go ahead and start that breastfeeding journey. Lactation suppression. So for those moms who do not choose to breastfeed, there are some things and some education that needs to be provided there. So these moms may have some engorgement that usually is going to occur about 72 to 96 hours post-delivery. So these may be moms who have already been discharged home. So we're going to want to make sure that we're providing a lot of education on this prior to discharge about what to expect. So those moms who choose not to breastfeed, you're going to kind of do pretty much the opposite of what you're going to do with the breastfeeding mom. So if they're not going to breastfeed, one of the things that we're going to tell them to do is do not stimulate the breast. So as I said, it's a supply and demand. So if there's any type of stimulation that occurs, your body's thinking, oh, I need to make milk. So we're going to try to stop that process. So we don't want any type of stimulation. A lot of times we'll tell a mom to wear like a tighter fitting bra. Obviously not too tight, but you want it to be a tighter fitting bra. You don't want it to be loose. That's going to kind of help bind those breasts. Also, when moms are taking a shower, you don't want them standing in front of a warm shower. The warm water is going to flow over the breast. That's going to, again, kind of encourage that stimulation. No hand expression. So sometimes I've heard moms say, oh, I'm going to express a little bit to get some relief. Well, again, you don't want to do that, because once you do that, that's telling your body, oh, I've expressed some, now I need to make more. So it's kind of stops that process. So you don't want to do any of that. You can also even put ice on the breast. So I think, you don't want warm water. So what's the opposite? You can use ice or cooler, a cool washcloths to kind of help that area too, especially as they're starting to have some of that engorgement. But definitely no stimulation, because that's only going to, it's going to be the opposite of suppression at that point. With health promotion for future pregnancies and children. So with the rubella vaccination, so with this, moms should not receive the rubella vaccination during pregnancy and up to 1 month post-delivery. You do not want them to have that. That's very important to remember. With the varicella vaccination, the Tdap. So sometimes if moms are behind on some of their vaccines, some of them they can get during pregnancy, or they may actually get them in their immediate postpartum period. So if you haven't seen this, that may be an opportunity that you guys may have. So if a mom needs her Tdap, for example, sometimes we'll give those before she's discharged home. So you may get to see that in the clinical setting as well. And then preventing RH immunization, or ISO immunization. That's going to be that RhoGAM vaccine. Sorry, not vaccine. That's going to be your RhoGAM injection, and that moms are going to receive if they have a negative blood type and the baby has a positive blood type. And so we'll talk more about that in detail later on as well. So psychosocial needs assessment. This is going to be gauging their reaction to their birth experience. This is really important for those moms who potentially didn't have the birthing experience that they wanted. Maybe they wanted a vaginal delivery and had to have an emergency C-section, or maybe they thought they were going to do birth natural and ended up with an epidural. So we kind of want to gauge their reactions on what their birthing experience has been. Also looking into their feelings about themselves, how they're interacting with their new baby. Because again, we're advocating for the baby as well. So if we have a mom who is not caring appropriately for her baby, who is sleeping through feedings, those are all things that we need to be mindful of, and be aware when we need to notify CPS if this may or may not be an appropriate interaction this mom's having with her baby, and when we may need to do those interventions to make sure that the baby's going to be cared for appropriately. And then interactions with other family members. Again, family dynamics can be fun in OB for sure, but we definitely want to make sure that we're sending that baby home in a safe space, and that our mom is being sent home in a safe space as well. And then engaging her with her current emotional status and her needs. And so we're going to be looking at postpartum depression. So when looking at our perinatal mood disorders, we need to be very knowledgeable about postpartum depression and how to use the Edinburgh Postnatal Depression Scale. A lot of times we are now doing this screening prior to delivery. So this is just several questions that we ask upon discharge to gauge the postpartum depression rating for these moms. Especially, again, if you think back to one of our test questions even, we talked about how do we know a mom is predisposed to being having postpartum depression, is if she's got depression coming into pregnancy. She's at increased high risk for developing postpartum depression as well. So we want to educate these moms on postpartum depression. Again, I think our book said 1 out of every 7 moms. It is much more common than that. I just think people don't talk about it, and people don't seek help. I think there's still a lot of stigma that surrounds that, and so we want to make sure that moms are educated on, this is normal. These are all these hormone changes that are occurring post-delivery, and so we want to make sure that they know that they're not alone, and that this is a very normal finding that can happen post-delivery, and so that they will seek care if needed. All right, so continuing on, this slide is kind of a repeat of some of the stuff in the previous slide. So we're just going to be looking at the effects of the birth experience, the adaptation to parenthood, and the parent-infant interactions. Again, just making sure that the interactions are appropriate, the baby is being cared for appropriately, and when we need to intervene. The family structure and the functioning of that family, and the effect of the cultural beliefs and practices. So this can be important when we have certain cultures who do things differently. And so one example that comes to my mind is that I had a patient one time who, in her culture, they believed that the mom didn't need to do anything, didn't even need to get out of bed for the first 2 weeks post-delivery. And so that's really important to note, because we had all these women who came to care for this mom, and they didn't want the mom to do anything. So they were caring for the baby, they were caring for the mother, and the mother didn't refuse to get out of the bed. But that's where, if you kind of go back a couple of slides, and we're talking about how important it is that these moms are ambulating, that they're getting up and voiding every couple hours. Those are conversations that we need to have. While we want to be respectful to their culture, we need to also educate them on why we're needing them to do these things. And so in that situation, once I explained it to her, they're like, oh yeah, that's fine. We'll get up and pee every couple hours, and I'll walk in the hall, and then I'm going to go back to bed, because that's, her culture and her beliefs. And so a lot of times you can have a win-win with that situation. You just need to be very open to communicating with your patients about why we're asking her to do these things, and then also us being understanding that this is her cultural belief and why they're acting in a certain way as well. So discharge teaching, again, this is just a little bit of a review of some of the things we already talked about. So we're going to want to make sure that we're covering self-care and signs of complications. So this, again, discharge teaching is going to start from the very beginning of when that mom is admitted to the floor to the time that she goes home. Because, again, there's so much information that we're throwing at her the entire stay while she's there. So self-care, signs of complications, when does she need to seek care, when does she need to return back to see her provider, sexual activity and contraception. So sexual activity, we recommend nothing in the vagina for up to 6 to 8 weeks post-delivery, whether they've had a vaginal or a cesarean birth. So this includes, any type of intercourse, tampons. We don't want anything in that area just because of the risk for potential infection. Contraception is a big conversation that we need to have with these patients as well. Moms are highly, highly fertile after having a baby. And so I cannot tell you how many times I've actually seen this happen, where moms come back for their 6-week checkup and they're actually pregnant again. They did not realize they could get pregnant that quickly. It can happen. It's not ideal. We want to give their bodies time to recover, and so we need to start having those conversations about contraception pretty early on. And so, again, that's why it's so important we educate on no intercourse that first 6 to 8 weeks until they've had that postpartum follow-up with their provider. And then sometimes, with birth control, they need to be on it a good 30 days before it's really effective. And so if moms have questions about that, so I've seen some providers go ahead and start them on contraceptive from the day that they are discharged. So again, it kind of varies per provider, but those are conversations that need to be had. Medications. So this is going to be very individualized depending on what's going on with the patient. So we usually like for them to continue their prenatal vitamin even through their postpartum period, especially if they're breastfeeding. We want them to continue getting those additional vitamins. And then, whatever their routine medications happen to be. So if it's medications they need to continue, if maybe they had pregnancy-induced hypertension that has now resolved, then, that's a conversation we'll have with their providers as well if they need to continue those medications or not. Same goes with insulin, or if they're diabetic, how we're going to have that treatment be after delivery. And then, of course, their pain medication, depending on if they are a vaginal or a cesarean delivery, it may vary as well as far as what they're being discharged home taking. So we're going to want to make sure that we're providing a lot of education on that as well. Follow-up after discharge. So routine schedule of care. So they're usually going to follow up with their OB provider. If it's a C-section, a lot of times they'll follow up in 2 weeks. And then again at that 6 to 8 week mark. If it's a vaginal delivery, a lot of times they're going to follow up just at that 6-week mark. With the newborn, a lot of times they're going to have the newborn to follow up with the pediatrician anywhere from 24 to 72 hours post-delivery. It just varies depending on the provider and if the baby's formula fed versus breastfeeding. Home visits, depending again on the provider and what the opportunities are for that. I know a lot of times some providers are doing telehealth, especially if a vaginal exam is not required. Sometimes they may do a follow-up telehealth visit too. Telephone follow-up. So I know at TJ we actually have one of our nurses that actually calls the patients a few days post-delivery just to kind of check in and see how things are going, especially with our breastfeeding moms. Usually it's those first couple of days home they're going to have a lot more questions, and so we want to make sure we're doing those follow-ups just to ensure that moms are doing okay. Warm lines, so that's where moms can reach out to us, because even though we've done a ton of teaching while they've been with us in the hospital, a lot of times, again, we've overwhelmed them with so much education. So we want them to have the opportunity to reach out to us with any questions. And then support groups. There are a lot of community support groups, especially I know in Glasgow there are several, and so we want to make sure that moms are aware that they have support groups in the area, especially with breastfeeding and just new moms. A lot of times, if not everybody has a village, not everybody goes home and has family that can step in and help, and so sometimes that can be really supportive and helpful if they know that they have people that can kind of help them through this postpartum period. And then referral to community resources. So this may be maybe the WIC program, where moms can get help with formula, or if they're breastfeeding, they can help get a breast pump, or with that WIC. So we start off at WIC with formula, and then also the HANDS program. So the HANDS is really great for those moms who are new moms. With the HANDS program, they actually come to their home and kind of walk them through those first couple of years. They come do home visits with them, and so the HANDS program is really, really good. So I highly recommend moms to look into that if they've never heard of it. And so we want to just make sure, again, people just don't know these resources are out there. So we want to make sure we're putting this information in their hands. All right, so key points. I'll let you guys kind of read through. All right, and then you have your question here that you can kind of read through. And so those are the only 2 chapters I'm going to do tonight. I'll cover the next chapter on Thursday night. It's a little bit shorter, and so I'll just cover it in class on Thursday. If you guys have any questions, please feel free to reach out to me.